Welcome to RUMC Vital Signs. I'm Alex Lutz. On our show, you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning, full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit rumcsi.org. According to the National Institute of Diabetes and Digestive and Kidney Diseases, approximately 20% of adults in the United States have gastroesophageal reflux disease, more commonly known as GERD. This translates to about 60 million Americans. Here to discuss this common condition, its causes, and potential complications if left untreated are board-certified surgeons Dr. Alex Barkan and Dr. Loren Harris. Dr. Harris is board-certified in general and thoracic surgery. He received his medical degree from the New York University School of Medicine and completed his training in general and cardiothoracic surgery at New York University Medical Center. Dr. Harris specializes in minimally invasive surgery using the latest robotic techniques for both benign and malignant diseases of the lung, esophagus, and metastaseum. Did I get that right? Mediastinum. Dr. Barkan attended medical school at St. George's University School of Medicine, followed by a general surgery residence at Maimonides Medical School in Brooklyn and Hahnemann University Hospital. He then completed a fellowship in minimally invasive surgery, as well as laparoscopic and robotic surgery at University Medical Center of Princeton. Welcome to the show.
Thank you.
Thank you.
Thank you. There's actually, what causes GERD?
Well, I mean, there are a lot of causes of GERD. The most common is no real identifiable problem. But the next down is probably hiatal hernias. And the most common of the hiatal hernias is what we call a sliding hernia, where part of the stomach just slides up into the chest. And the reason that causes GERD is because the lower esophageal sphincter is actually not an anatomical sphincter. It's a pressure-based sphincter. In the normal anatomy, about 2 to 3 centimeters of esophagus is below the diaphragm. And the pressure difference between the stomach and the chest keeps that area tight enough where there's no reflux. But once you have a disruption of that anatomy, many times there is reflux. So the most common reason is no known or no identifiable cause. But anatomically, the most common cause is a hiatal hernia. Other causes include things like obesity can lead to reflux, just because of the, Alex is better at this than I am, but because of the weight of the abdominal cavity changes that pressure difference. So they have a higher tendency for reflux. Manometric disorders of the esophagus, motility disorders of the esophagus can lead to reflux. And there are certain medications that increase your risk of reflux.
And what are the symptoms of GERD?
Well, it's funny because about half of the people who come to see me and in the literature who complain of heartburn and they think they have reflux, about half of those patients don't have significant reflux at all. So many times the symptoms are very hard to really track down. They mostly include heartburn. They may include things like recurrent pneumonias from aspirating at night when they lay flat. The contents come up and they go into the lungs. You can get recurrent pneumonias. They can have changes in their swallowing, changes in their bowel habits. All those things can be related to reflux. But the most common is really is what people call heartburn.
And is it more noticeable, the symptoms in the evenings? You talk about like laying down. Is it more noticeable then, or is it happen at any time?
Oh, there are people who have it all the time. There are people who only have it at night. It sometimes can be related to when you ate your last meal, how much you eat. People who eat large meals, right before going to bed, many times will have more reflux. And one of the things we do to try to medically treat reflux is weight loss, not eating a large meal before you go to bed, and elevation of the head of the bed. A lot of times that will help control the symptoms. So a lot of times they do complain at night that they get this reflux, this heartburn.
And Dr. Barkan, Dr. Harris alluded to weight loss and bariatrics, and you founded our Bariatric and Metabolic Institute. Why is someone who would be a candidate for weight loss, or why is GERD a prevalent symptom in someone like that?
Obesity might contribute to intra-abdominal pressure, which pushes on the diaphragm, sometimes loosening it up and making GERD more common from that standpoint. And so patients who have GERD, one of the gold standard treatments surgically is a gastric bypass. So patients who come to us who have issues with living with weight and also have GERD related problems or diagnosed with GERD on endoscopy or what other tests, we actually offer them a gastric bypass, and that completely takes their GERD away 100% of the time.
Oh, wow. So it sounds like GERD is something that a gastroenterologist initially diagnoses? Well, how would you diagnose GERD as opposed to being, oh, somebody just has heartburn?
Well, I think that there are several ways that patients come to us with the diagnosis of reflux. But endoscopy is one of the clear ways of doing it. There are certain findings on endoscopy that are proof positive of significant reflux. Things like something called Barrett's esophagus, which is a change in the lining of the distal esophagus, can be even up to proximal esophagus, depending on how much acid exposure the esophageal lining has.
So is this like an erosion of the lining? Is that what you're talking about?
It's a change in the lining it's a metaplasia. In other words, the normal lining changes to intestinal type lining, which is something that you don't normally see. And on endoscopy, these patches of Barrett's look kind of pink in nature. And when you biopsy it, the pathologist will tell you there's this intestinal metaplasia, which is consistent with Barrett's esophagus. If you have Barrett's esophagus, you have significant reflux. Other things like something called a Schatzki's ring, which is a fibrosis of the distal esophagus from constant reflux of acid, and it fibroses and it causes an actual ring there, and people can have difficulty swallowing, and that's proof positive that you have reflux. So many times when the endoscopist looks, he can see or diagnose significant reflux. There are other ways, because not everybody has those. In fact, only a small percentage of people have that. There are other ways. There's something called manometry and pH testing, and there are specialized labs that do this test. They have a thermistor or a catheter that they put into the nose, and it measures a lot of things. It looks at how well the esophagus moves when they swallow either liquid or solids, and it can also measure the exposure of the distal esophagus to acid. And if they meet a certain criteria, then that's proof positive that they have significant reflux and that they may be aided by medical treatment or surgical treatment.
And so as surgeons, if someone has GERD, I mean, not everybody has GERD needs surgery, right?
Correct.
So at what point is surgery like recommended, or like this, you look at a case and you say this person absolutely needs some kind of surgical intervention to cure their GERD?
So going back to the patients who's living with weight who also has reflux diagnosed with Barrett's, again, gastric bypass is gold standard to treat because Barrett's can turn into cancer, and that's the risk of Barrett's.
Okay.
And there's short segment Barrett's and long segment Barrett's, and there are different treatments for Barrett's, but a patient who has weight issues, who qualifies for weight loss surgery and Barrett's, gastric bypass is a great option. There are other techniques used for repair of GERD, endoscopic techniques that are available, and also surgical techniques. There's a procedure that lines magnets around the esophagus, recreating the sphincter, recreating the muscle that was loosened due to whatever reason, and that recreation of the muscle tightening also prevents GERD. So there are different evolving techniques to help patients with GERD, because many patients are on medications all their lives without significant help, and they don't know who to turn to for surgery, because sometimes medical physicians don't refer for surgical treatment because medical treatment is available and works a lot of percentage of the time. So patients don't know that they have options outside medications, which sometimes is not enough for them.
Right. And what are some of the I'll say, at-home medications that treat GERD?
So there's different classes of medications that treat GERD, and some commercial names of medications we know, such as Pepcid or Prevacid, or along those lines. They themselves have potential complications and issues. For example, Prevacid or omeprazole can cause gastric polyps that are not dangerous for the most part that we know of, but there can be many of them. Sometimes they could bleed, sometimes they can cause other issues. So these gastric polyps occur in patients who are on long-term PPIs or Prevacid or Pepcid. Now, Pepcid is a different medication, different class. It's been around for a long time. It's available over the counter. It doesn't need a prescription, but it can cause certain blood issues and it can cause certain other problems. So these medications are not benign if people continuously take them for a long period of time.
Yeah. Can GERD be caused by certain medications that people are on?
Well, the answer is yes. I mean, for example, today with the advent of weight loss medications, the injectables that we use, they cause GERD because they slow down the stomachs and they can cause problems as well, long-standing problems as well.
So when you actually are, so actually let me answer a question. We talked about it before, again, the weight loss. So you've been on the show before, but you want to just remind the people who watch, how do you qualify for weight loss surgery? What are the qualifications? Whether you have to meet?
Well, you have to have a certain body mass index. Your weight and your height goes into a formula and the number comes out. And a BMI of over 35 with medical problems, such as sleep apnea, such as hypertension, diabetes, those qualify for surgery. Patients who are BMIs over 40, they qualify for surgery just on its own. But usually that's about 80 to 100 pounds overweight. And those patients qualify for surgery as well.
And as surgeons on Staten Island, are you performing a lot of surgeries for GERD?
Well, Dr. Harris with thoracic specialty specializes in intrathoracic issues,
Right.
and sometimes these hiatal hernias can be very difficult to deal with. They can be they're chronic. Many patients live with them for many years, not knowing they even have them, and also not knowing that they can be fixed very nicely with robotics these days.
Right.
And so doctors don't refer these patients until they have difficulty with eating to the point where they're spitting up their food, they're sleeping, sitting up at night in a chair because they can't lay down because of the severe reflux. And so in the past, open surgery was very difficult to do these paraesophageal hernias that are sitting in the chest because you couldn't directly look into the chest. You would have to use blind finger techniques to sweep out. It was a very difficult process that rarely was done. With the advent of robotics and laparoscopic surgery, we're actually able to see into the mediastinum, we're able to see into the chest, and we actually can do a great job of reducing that anatomy and helping people restore their quality of life that they didn't realize they can actually have these surgeries. So those are very important things that we offer as surgeons.
And are you seeing a lot of cases of GERD? I mean, like surgical, but is GERD something that's prevalent on Staten Island?
Well, I think it's as prevalent as anywhere else. But, you know, we don't see, as Alex said, I mean, we don't see a lot of them because it can be controlled medically.
Right.
And a lot of the people who are seeing these people first, the gastroenterologists, their internists, are treating them medically with good results. So if you treat a patient with a medication and their symptoms are relieved, there's no real drive to send them for surgery.
Right.
What happens is that some of these medications are very expensive, and the patients just simply get tired of taking them or can't afford to really pay for these medications long term, and that's when they will come to us. And that, for me, that's actually a bonus, because one of the ways you can diagnose GERD without doing anything really too invasive is to ask the patient, were your symptoms relieved by these medications? And when they say yes, you say, well, when you stop them, did the symptoms come back? They say yes, that's pretty much a good sign that what they're experiencing is true reflux. Because, like I said before, only about half of patients with symptoms actually have reflux. So those would be the patients who they put on the medications and nothing happens, or very little happens. So, because you can always make them worse. So you have to be very, very careful who you choose to do these procedures on, other than the bariatric patients, of course. But yeah.
Well, I mean, for me, it's an eye opener that GERD can actually raise your chances of cancer.
Yes.
Because I think a lot of people just think of GERD as some kind of harm. Like they hear about it on TV so often that it's some kind of just harmless reflux, and I'll deal with it medically. I don't need surgery, and then to find out it potentially could lead to cancer is, to me, a little startling.
Right. Yeah, I mean, it's fairly common knowledge in medicine that this is the case. And there are patients out there who don't even realize that they might have Barrett's. The 1-2 cells of Barrett's is already considered a diagnosis of Barrett's, even though clinically they might not have symptoms of Barrett's. And so that's an important thing to continuously watch in patients who do have GERD or symptoms of GERD who had it for a long time.
Wow. So when we talk about surgery, so now we talked about gastric bypass is one of them. What's another type of surgery that alleviates GERD?
Well, as Alex said, there are several different types of procedures. There are endoscopic procedures that can reduce reflux. There are the magnets that Alex talked about, and both of these types of methods have pretty good results. But the surgical procedures are generally fixing the hernia, which is usually associated with it. By the time they come to us, most of these patients have hernias, and doing something called a fundoplication. And a fundoplication is where you take the fundus, or the top portion of the stomach, and you wrap it around. You either do a partial wrap or a complete wrap around the distal esophagus. And what that
distal
does,
is the bottom part, or
just
for those of us that are
the bottom part of the esophagus that is now underneath the diaphragm. Because when you repair the hernia, part of what you do is you mobilize the esophagus enough that that very end portion now sits below the diaphragm the way it did when you were born. And that reestablishes some of that mechanism, but we bolster the mechanism by wrapping the stomach. And that kind of shores up that distal mechanism that prevents reflux.
And that's a really effective procedure?
It's a very effective way of doing it. And now with robotics or other forms of minimally invasive techniques, these can be done in a matter of an hour to 2 hours. And generally, a lot of patients are going home the same day.
So all this is done you do primarily do it robotically?
Of course, it's available robotically, and as Dr. Harris said, the patients can go home the same day, which is a tremendous thing compared to what was in the past, the days in the hospital, x-ray studies, what have you. But here, it's because the visualization is so great that we're able to really feel confident about the work that we do using the robot in this situation.
And what's the name of the procedure with the magnets?
It's called a LINX procedure. It's called a LINX procedure. And basically, it's a series of magnets in a ring. And what they do is you place it around the beginning of the stomach, just below the diaphragm. And these magnets sit close to each other because they're magnets. But you have to continuously, for a period of time, eat a special way. So the magnets open up and close. And the point is that so tissue doesn't grow in between those magnets to prevent them from closing. So it's a bit of a process. It's a workup technique. It requires the magnets themselves, which is something that we can, bring into RUMC as a new technique, for example. But that's an option for patients as well. And many patients who've had, for example, weight loss surgery, like a gastric sleeve, sometimes they have reflux as post-procedural issue that we do discuss with them as a possibility. And those patients can qualify if they have reflux. They can qualify for some of these other procedures outside a traditional gastric bypass.
And how many magnets are we talking about? I mean,
it's basically a ring, and it's a series of 7 little magnets in a ring. The ring gets placed around, and then it gets tied, and it causes a certain tightness around the esophagus, and recreating the lower esophageal sphincter, which is a lot of times the reason why reflux is occurring. There's a loss of tone in the muscle, and so we're recreating that tone again.
And what is gastric bypass surgery?
So gastric bypass surgery is basically we make a small stomach out of the original stomach in the size of an egg, and we bypass about 2 feet of small bowel. So if you think about the letter Y, one part of the Y connects to this new stomach that we make.
Okay.
The other part of the Y connects to the old anatomy, which is still intact, producing all the necessary juices for digestion. And then where the Y meets, the leg of the Y, is where food is not being absorbed. So the small stomach, lack of appetite, and the bypass allows for weight loss, and also diabetes control and reflux control.
And so because it's a smaller stomach, is that what alleviates the GERD?
No, the bypass is what alleviates the GERD. You prevent the acid from traveling up back into the stomach, because if you're bypassing about 2 feet of bowel, that's the amount of distance the acid has to travel backwards, and it doesn't do that because bowel only functions one way. Bowel peristalsis only one way. It doesn't peristole in reverse. It only peristoles with it. So it prevents acid from getting back into that stomach.
And so, as you said before, you're using robotics in a lot of these procedures. How has that robotic surgical system been a game changer for what you guys do?
It's a total game changer. In the bad old days, we used to do these procedures open, meaning either doing a big incision in the middle of the abdomen, or sometimes we would go through the chest. There were several operations designed to go through the chest, which would require an open technique as well, and that takes longer to heal. It's more painful. With the robot, the first of all, it's three-dimensional vision. You can see everything as though you were actually inside the abdomen yourself, and everything is the dissection is just as accurate as with open surgery, and it's actually, it makes the surgery much easier, honestly, from a technical standpoint. And there's nothing you can do open that we can't do robotically.
And I imagine using the robot, you talk about less recovery time, less pain, all the things for patient quality, and I've seen from what I've seen at the hospital, you guys, your wrists only do this, or robots goes around, so it gives you that ability to do. And I imagine using the robotic system actually cuts down on the actual surgical time.
Right. It does. It does.
Absolutely.
Surgical time.
Don't have to open and close. You're making very small incisions, so all that, you save a lot of time. And the instruments themselves are like your wrist. They move in the exact same direction, and they basically perform the same function as the human hand.
And robotic surgery has been around roughly how long now?
It's probably around since 2012.
In one form or another,
I started the robotics in 2000. The robotics has probably been around since 2004.
Oh, okay.
When I was still a resident. They started with heart surgery. I started using robotics around 2012, and since then we've been pretty much doing everything we can robotically, and so that allowed us to do patients who are difficult patients, difficult anatomy. The visualization is fantastic, and that really is a game changer for patient care. I mean, a large patient who might have a wound infection from a big midline wound, or a breakdown of that wound requiring further surgery, that's all prevented with these little incisions and great visualization.
But I'm imagining on your parts as surgeons, there had to be a learning curve for you guys when robotics came along. And whether this was something that was going to take off, or was this something that was,
Well, I mean, it's like any other technology in medicine. At first, there's only a brave few using it, and everybody else is saying, "Oh, it's never going to work." And you eventually mature to the point where everybody's now using it.
Right.
And the technology has changed as well. The original robot versus what we're using now. Actually, there's a new version of the robot that has also come out now. Not that much different than the one we're using now, but there are some advantages to the new system. But yet the hospitals have to embrace the increase in cost, which clearly there's an increase in cost from the surgeon using regular instruments through an open incision to using this technology. But the payoff is shorter lengths of stay, less narcotic use, and actually shorter surgical times, with blood loss and so forth being much lower. So the robot has matured over time, and it's gotten to the point where it's once you're used to using it, it's very easy to use. And there is a process by which you don't just walk into the operating room and use the robot. You have to go through training. You have to go through technical training about the actual functioning of the robot. Then you have to do cadaver. You have to spend time with a cadaver doing robotic techniques within a cadaver, and then you have to be proctored by somebody who is well known or is an experienced surgeon for your first few cases. So it's a step up kind of process, but once you get there, there's nothing quite like it.
And from a patient standpoint, is there a hesitancy when you tell someone you're going to be working on them robotically, or is that people kind of just, it's the norm now?
Patients, they have a tendency to think that when you say robot, they think the robot is doing it on its own. I tell patients it's just an extension of us. It's just a tool that we use, but it's us doing the work. It's just that it's technically much more superior, and I sort of alleviate those notions that this robot is somehow doing something on its own without anybody's control.
Yeah, it's definitely not.
No,
Definitely not.
there's a lot of safety measures in place.
Sure, I can imagine it, but I get the visual. There's some robot like the Terminator working on it.
Well, the one concern a lot of my patients have is, are you going to be in the room while this is going on? And of course you are. And the surgeon sits a few feet away from the operating room table, and there's an assistant at the table, including a scrub nurse. So there's plenty of people very close by. There are no real issues as far as that's concerned.
So it sounds like if someone thinks they have GERD, that there are surgical interventions that can cure it, it sounds like. And there are others that there's the opportunity to take care of it themselves. But basically, it sounds like GERD is not something that someone should just dismiss out of hand if they think they're experiencing that. So I want to thank you guys for coming on the show.
Thank you.
Thank you.
If you think you may have GERD and would like to schedule an appointment with Dr. Barkan, you can call 718-818-4020. Dr. Barkan's office is located at 1161 Victory Boulevard, inside the Dr. Krishni Ers Medical Pavilion. Dr. Harris can be reached at RUMC's Department of Surgery by calling 718-818-2420. Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for over 120 years. You can help ensure that care continues by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the donate button, which is located at the top of the homepage, or you can call 718-818-2106. That just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.